Once cleaning and shaping is completed and the canal has been dried with paper points, now we're ready for root canal obturation. For this process, we've historically had many options. Personally, I obturated the first 1,000 cases of my career using lateral condensation, then I did the next 14,000 with vertical condensation, but since 2008 I've obturated the last 12,000 cases that I've completed clinically with a far more efficient and simpler obturation technique called hydraulic condensation. Now, hydraulic condensation is a quick and simple obturation technique that was developed by Drs. Koch and Brave and myself here at Real Endo. This technique combines the use of a biocompatible, antimicrobial, dimensionally stable, dentin bonding, hydrophilic, premixed calcium silicate material with a gutta percha cone that is silanated with bioceramic particles on the surface of the cone as well as inside the cone. Now, this combination creates a monoblock of bonded bioceramic obturation for the best seal and simplicity of technique possible. As an additional benefit, it also strengthens the root. So no backfilling or excessive compaction forces are needed to complete this technique, and that helps strengthen the root. You simply place some sealer in the canal either by direct injection with the syringe, being very careful not to inject to the apex but only in the coronal half of the root, and then pushing the sealer down to the apex using a hand file or a rotary file in reverse, or you can carry the sealer directly into the root canal using a hand or rotary file, much like any of the traditional techniques. You then butter up and coat your fitted BC gutta percha cone, inserting it gently to length while allowing the excess sealer to escape out and around the cone to vent up around the cone coronally. You then melt the gutta percha handle off at or slightly above the orifice using a heat source and lightly compact the molten stub with a large plugger to create a nail head of gutta percha covering the entire orifice. This action covers any seams of sealer and allows you to wash the excessive sealer on the chamber walls either with an ultrasonic energy and water or with a moist alcohol cotton pellet without disturbing the sealer inside the root canal. This technique is extremely efficient and predictable, and now after thousands of clinical cases and many 12-year recalls, I'm confident of its success and longevity as well. It's important to know that hydraulic condensation is not merely a single cone technique. It's actually a bonded obturation technique using hydraulic bioceramic cements. Now, in small canals, once a shape has been milled in the canal with your file, you only have room for one cone because the canal gets the shape of that particular file. But in a more oval canal, like the distal root of a mandibular molar, you can add additional cones around the main cone to occupy space and to reduce the chance of voids. The bioceramic cements used for this technique are BC Sealer or BC Sealer High Flow. The main difference between the two is particle size and flow. The high flow is also a little bit more radiopaque and heat resistant. During the past few years, I've switched completely to using BC Sealer High Flow for my hydraulic condensation cases, since cases look better radiographically due to its higher radio opacity. But you will have the same success rate using conventional BC Sealer or BC Sealer High Flow. Hydraulic condensation is a simple and effective obturation system that's supported by literature and has now become the gold standard of root canal obturation. It's simple, it's effective, and because it eliminates many additional gadgets like a gutta percha injection gun or thermoplastic carriers from your endo armamentarium, it's also a more economical option for your obturation. Lastly, much like bonding in restorative dentistry, bonded obturation has helped reduce dentin removal during root canal preparation, since deeper fitting of pluggers and spreaders that was required for traditional obturation techniques is no longer required. We're able to be more minimally invasive in our preparation by limiting our instrument tapers to 02, 04, and at the largest to an 06 taper preparation during our instrumentation. This saves tooth structure and helps reduce the potential for biomechanical root fractures down the line. This technique is now time-proven, and it's also interesting to note that the very first clinical case done in the US in 2008 was done by myself the day after its FDA approval, and this tooth is still functioning and is asymptomatic. I hope you give this technique a try and reap its many benefits for your patients. As usual, drop me a line if you have any questions on this topic on the social media on our own website.